Good morning, students. Today we have Professor Sudhir Kumar with us. We'll be talking about a case of avascular necrosis of hip. This is a common long case which is given to you in your practical examination. So, Professor Sudhir Kumar will share with us his pearls of wisdom. Good morning, sir.
Very good morning, Dr. Harpreet.
So, this is a common case which a student is presented with, and usually at the end of his history taking, he's asked to summarize his salient points of history. So, how do you suggest the students should go about presenting his salient points of history?
Yeah, in fact, the positive history is important as well as certain negative points. So, to start with, the patient in fact presents to you with an insidious onset of pain. And he may just tell you that he started with a morning stiffness, which possibly over the period of time as the sun rises, as the day rises, the pain gets eased out. Then he starts telling you about stiffness in the pain, stiffness in the hip. And this stiffness and the pain, it slowly progresses over a period of time. And then he also will tell you that his walking distance gradually diminishes and he gets tired on his hip very easily. At the same time, the patient may not have pain in the hip joint, and he may just tell you that he is experiencing pain in the knee, while as such, when he's sitting around comfortably sitting on a chair, he doesn't have any pain on the knee at all, but he can move his knee all right. So that should raise a suspicion that his hip is involved. While describing the history, certain very events or the personal habits must be taken into account. Like, is there any history of alcohol intake? Alcohol intake, regular alcohol intake is the most important aspect. Young people may be on steroid and they take anabolic steroids for developing or making their muscles look stronger or bulky. So they could have at times they could have renal problem, or they may be suffering from diabetes. This is the history points that should be elicited upon. And of course, there are certain other negative history that you should ask for, that has there been any history of trauma preceding this pain, and has there been any prolonged history of fever or constitutional symptoms like loss of weight, night pains, or having a contact with a tubercular patient, or in fact involvement of any other joint, or stiffness in multiple joint should also be taken into consideration while eliciting the history in these patients.
So important to take the negative history as well, just not the positive history, just not the positive complaints the patient is talking about, also the negative history, because you want to rule out other differential diagnosis. So coming to differential diagnosis, sir, at the end of his history, what all differential diagnosis should the student tell to the examiner?
After having collected the subjective complaints of your patient, a data is being raised. Based on that data, you should suspect, is your patient having a avascular necrosis of the hip, which is like having coronary on a femoral head. And very rarely in our country you come across primary osteoarthrosis. But primary osteoarthrosis in a young man is very highly unlikely. very highly unlikely in our country. Particularly, the tuberculosis of the hip joint is the one which is endemic in many places in our country. So that must be kept as a differential diagnosis. While in females, are transient osteoporosis of the hip in females is the one which normally resolve over a period of time. However, a secondary osteoarthritis of the hip joint, which occurs in middle age group, in old healed Perthes disease, or dysplasia of the hip, or if the patient had fractured neck of femur in early childhood. These are the differential diagnoses that should be kept in mind. However, monoarticular rheumatoid of a bigger joint is a highly unlikely situation in our part of the country.
So in history, we keeping these as differential diagnosis, but while taking our history, we need to take remember we have to take out history points so that we can also ruling out these differentials. So as you said, age is an important criteria. This osteonecrosis would be a young person, whereas a primary osteoarthritis would be more common in a elderly. Also, a past history of some problems in the childhood, like a Perthes or DDH, they have to be taken.
Or slipped capitofemoral epiphysis. These are all old sequelae of the septic arthritis of the hip joint. They need to be kept in mind also, but your history would be able to negate these findings.
So important, take a good history. This is a long case. You have to be meticulous and comprehensive in your history taking. So when the examinee is presenting his positive findings on the examination, what all things he should talk about, which are the salient findings he should present to the examiner?
Uh, the patient will have endalgic gait, which is classically found in these patients. There could be also short limb gait. So there could be also combination of these two. And so one should be very careful in assessing these patients and make them walk for a little while and observe them from front as well as from the side. And the affected hip will have a flexion deformity, and most of the time they may not have any fixed deformity of abduction or adduction. There may be a jog of movement available to you in these directions. So similarly in rotations, rotation may be restricted. In external rotation may be restricted, and internal rotation may be available to you to a little more degree than the external rotation in extension, and there will be a shortening, true shortening in these patients depending on what stage they present to you. A very important feature that you have in these patients would be a sectorial sign, a sign in which you find that there is a differential rotation in extension and flexion. So depending on which part of the head of the femur is involved to start with. Mostly it is the supralateral part. So in supralateral part you find that when you flex the hip joint, as you flex the hip joint and you're nearing to the 90-degree, it goes outward, suggesting you that this is an axis deviation and there is a differential involvement of the femoral head.
So, two important findings in these patients, as sir mentioned, would be axis deviation. As you flex the hip, the knee goes into external rotation, goes towards the same side shoulder, and a sectorial sign, which is differential rotations in hip extension and flexion. So, these would be important findings. Don't miss them, and you may be asked to demonstrate them. Just be meticulous with your demonstrations. So, we already talked about the sectoral sign. Sometimes such patients present to us with bilateral hip involvement. So this becomes very tricky to demonstrate if there is a bilateral hip disease. The flexion deformity demonstration becomes a bit tricky for the examinee. So how do you suggest he should go about it? Is it wiser to do a Thomas's test only?
Well, you see, we normally we give a unilateral hip to our candidates in examination, because that is a test of examination. However, you get many a times bilateral involvement of the femoral head. So if you have to examine, then you must examine the opposite hip as well to find out that the opposite hip is absolutely normal. In case you suspect that opposite hip also has a deformity or restriction of movement, you should be performing a flexion deformity, which could be demonstrated on a patient by bringing the patient to the end edge of the couch and the patient to be made prone so that the trunk and the head lies on the couch and the limbs are hanging free at the edge of the couch. Both the limbs are hanging free at the edge of the couch. That will take care of the excessive lumbar lordosis. Then extend both the hip joint, and where it stops getting extended is the flexion deformity in either hip. So this is what we call as a stele prone test, which need to be done in these patients to demonstrate flexion deformity, fixed flexion deformity in bilateral hip joints.
So remember, as sir beautifully just explained this test, you will be asked to tell about this test in case the patient has a bilateral hip disease. Usually, as sir said, it's a norm to keep a unilateral hip disease, but sometimes bilateral hip disease patient may also be given to you in the examination. So at the end of the examination, does our differential change, or we'll keep the same differentials as at the end of the history? Sir.
At the end of your examination, you see, you are more or less sure that that your patient is suffering from a secondary osteoarthrosis of the hip joint, and probably the cause is osteonecrosis, because in infective hip, you will find global restriction of movements. And in osteonecrosis, you may find movements will be present in almost all direction to a larger degree.
So you'll say that your diagnosis is a secondary osteoarthritis with the etiology most probably as osteonecrosis. Should we go about saying like that?
Yes. So far as the history contributes along with it, and other inflammatory conditions can be excluded out from the history. However, the differential diagnosis still remains in the same order.
Okay. So a common question asked to the examinee is that why do you keep your osteonecrosis as your first differential? And so what answer should he give to the examiner? What do you expect him to be saying? That how has he excluded other causes? Or why is his first differential as osteonecrosis?
Insidious onset with slow progression, inhibiting his daily activities, like most most commonly the floor activities for which they are particularly used to, and without having any constitutional symptoms of evening rise of temperature, loss of weight, fever, and no other joint is involved. There is no other joint involvement with any deformity, and no contact with a tuberculous patient. And there is no history, there has been no significant history of trauma. So these characteristic findings will lead him to suggest that your patient probably has osteonecrosis. And in addition, if he has any intake of steroid, that becomes a positive factor.
So, disease, history suggesting hip disease with negative history regarding tuberculosis or inflammatory joint disease, and positive history of maybe a steroid or alcohol intake. All these go in favor of a osteonecrosis. So you have to spell out all these points.
And I think you should also mention that patient is not a chronic smoker.
Okay.
Even in chronic smokers, also this can result in the avascular necrosis of the femoral head.
So